Mm-hmm.
So we have 3 different
Politics.
shows.
Yes.
And I just signed up for a 4th one.
Uh-oh.
One of the biotech bloggers, amazing, the man has 10,000 people a day following him.
Wow.
Wants to go on TV.
Mm-hmm.
So he called me and he asked if I would do a show with him. So we'll see how that goes.
Very nice. Yeah.
That's going to be a very challenging show because we're going to do half an hour about the market
Mm-hmm.
and then get a CEO to come on. So getting the CEOs to travel and will be interesting.
Yes.
I think whenever you guys are all set, we should.
We're waiting for Mr. Nipmuck.
You all set, man? All right.
Does he need a sound check?
Give it a repeat sound check. Do sound check.
It's his first day.
They are interns, correct? Through the,
The intern.
that's a wonderful opportunity. You know, it's very nice.
Could you guys count 10 for me?
1, 2, 3,
3,
4,
4, 5. Oh, sorry. Yeah.
1, 2, 3, 4, 5, 6, 7, 8, 9, 10. He's narrowing down mine. Now he'll do yours.
1, 2, 3, 4, 5, 6, 7, 8, 9, 10.
We're good.
Perfect.
All right, quiet on, ready on set. Quiet on set. 5, 4, 3, 2, 1.
Well, we're continuously exploring the incredible services offered here in Milford at the various medical facilities. Tonight, we're going to look at state-of-the eye care, what's available for eye care, what advances are coming about, and amazingly, how you get them right here in Milford. So why don't we start with an introduction?
Well, thank you very much, Al. I'm Dr. Roger Kaldawy, and I am one of the 3 surgeons, ophthalmologists at Milford Franklin Eye Center. And we have 2 offices, one in Milford, one in Franklin. And I'm very happy to be today here with you. And I would like to thank you, of course, for your invitation to chat a little bit about eye care and in particular focus on what's new, what's state of the art, what's really coming as future technology to help us with our day-to-day eye needs. And I thought we can, if you can move to the next slide, you know, again, we have 2 offices, one in Milford. It's a relatively brand new office, very nice facility. We are 3 physicians. Dr. John Hatch is my partner. He's the only pediatric ophthalmologist in town. And of course, you know, we are privileged to have them because actually in this whole area, as a pediatric ophthalmologist, eye physician, we also have Dr. Cam Lashkari, who is a Harvard Mass Eye and Ear retina specialist, who is in our practice once a week. And of course, everyone knows the need right now for retina care with the macular degeneration, which is almost in an epidemic, epidemic importance, where we are all living longer and we're getting more macular degeneration. And we can touch base on this also if we have time today. And my specialty myself is cataract surgery, laser vision correction, and cornea with corneal transplantation. And I've been with the practice for around 14 years. My major interest right now is really cataract surgery. We are going to discuss together what's coming up with cataract surgery, what is a cataract, how do we treat it, and how can we, at the same time, do other benefits to the patient who has cataract by not only removing the cataract and the problem with the blurry vision, but also trying to repair the need for glasses and trying to reduce that need and improve the vision altogether.
Now, cataracts. Firsthand, you fixed mine. It's a scary proposition where over a short period of time, I saw my ability to drive severely impaired. It seemed like during the day, I couldn't read the signs on 495 anymore. I didn't know what was happening, but I knew I didn't like it. What are cataracts?
Yes, so we can move through the slides. We can stop at this one, and you will find that the eye has different segments. And the front part of the eye is the cornea, which is the window that is to the front part, allowing the light to get inside the eye. Behind the cornea, you can see that we have the iris. The iris is what gives the color to our eye. But then just behind the iris, there is a circular lens that allows the light to get inside the eye. And over time, as the lens, the human lens, interacts with the sun, UV A and B light, and also for genetic reasons and also for some other reasons like medications, this lens becomes cloudy. So now we have a problem with the light getting inside the eye and the vision becomes blurry. And as this happens, there are different things that can happen. And if you can jump all the way to the slide that will show the different symptoms of cataract, you can keep on going. And then it's just, you can see right here how the cataract is a white, cloudy lens inside the eye. There is a popular myth that, people tend to think that cataract is a membrane on the surface of the eye, but it's not.
Is it like a glycogen or some deposit or collagen?
It's actually, the lens has different fibers, and as we go through life, these fibers become thick, and there is extra deposit of fiber, and there is also thickening of the lens, but this comes with clouding of that lens. So that clouding then starts to cause what you have experienced, which is, glare at night. Just looking at a headlight, you see starburst around the headlight or around street lights. There are other issues with the cataract where people are having problems with reading, where the reading becomes difficult. And I hear people tell me all the time, doctor, how come I have to get a brighter bulb to be able to read what I used to be able to read with the same bulb? So people start to change their bulbs at home because things are getting dimmer. But then as this progresses, then we start to get the problem with the colors, where people have difficult discriminating colors. Faded colors. Everything becomes pale. But then at a later stage, then everything becomes fuzzy. And that's when the general impression of the word is that it's foggy and dim. The cataract surgery is really indicated when the patient has issues and symptoms. So it's extremely wrong for someone to be told by anyone that you have to have your cataracts done. The patient should tell the doctor, I'm ready for my surgery based on the symptoms. And therefore, when the patient has glare, when the patient has problems driving at night, when the activities of everyday life that were possible before are no longer possible, like playing golf or tennis.
My biggest issue was during the day.
Yes.
I'd be driving down the highway, and those big green signs became big green blobs.
Correct. And this is what we call glare around lights, and especially if there is a bright sunlight that can make this happen. So there is definitely an indication based on symptoms. When we have enough symptoms where the activities of everyday life are now impossible, this is when we start talking about cataract surgery. So a long time ago, we used to wait for the cataract to become very ripe, but with modern technology, we really do not count on the patient's cataract size as much as we rely on the symptoms, and if there are symptoms or no symptoms. And on this slide right here, we can see how classically we remove the cataract. Basically, we have to get inside the eye through a very small, tiny opening, microscopic opening. And then we get inside to the lens that is cloudy, and we make an opening inside the cover or the bag that holds that lens, and then we deliver the ultrasound that will make that lens softer. Then we vacuum that lens.
Now, when you say softer, so you're making what, a 3 millimeter cut in my eye?
Actually, it's smaller than this.
Really?
With modern technology and advanced surgeons are able to make even smaller than this. My incisions are 2.2 millimeters. So they are extremely small, and we do that to allow the patient, number one, not to have any side effects from the incision, such as the shape is not changed, but number two, for quicker healing and recovery and going back to normal activities after surgery.
So you make a 2.2 millimeter, which is amazing to me, cut. You bring an ultrasound probe in there,
That's correct.
and when you say soften, you blast the lens, or
Yeah, so the ultrasound energy will interact with the lens, and that lens becomes emulsified. It's in a way, think about it like you're trying to prepare at home like a fruit cocktail, and everything becomes one.
right?
So the lens becomes like white mud, and it becomes very easy to just suck it out. Whereas before, you just had to take it in one piece, and therefore you had to open the eye, which
Well,
was
you'd have to make a much bigger hole
much bigger hole.
to pull it out.
That's correct. Much bigger wound with the side effects that came with that wound, which
So you're
thankfully we don't have.
homogenizing my lens. You're turning it into mush,
That's correct.
and then
know,
you suck it out.
It's sucked out, and then it's replaced with an implant. And that implant, the nice thing about the implant is that it doesn't only replace the lens, but it also replaces any problems with your vision that are due to a problem with the glasses. So if we go to the next slide, we can show you here how now we have modern technology like bladeless cataract surgery is probably the most exciting technology that came up in probably in the last 20 years in ophthalmology.
Bladeless surgery.
Bladeless surgery, yes. And what bladeless surgery does is that it's using now a laser to do what the doctor's hand used to do. And by doing so, trying to improve on the accuracy of the procedure and on the safety of the procedure. And we do know that there are different steps that we describe. For instance, if we go to the next slide, I can explain how that original incision that you can see used to be done with a blade. Now we can do it with a laser. Not only can we do it with a laser, but we can use the same laser to make relaxing incisions on the cornea, such as we can now correct astigmatism. Because if you replace the cataract and you leave the astigmatism behind, then the quality of the vision after the surgery will not be as good. And although you can correct it with glasses, that quality will not be as good as if you can see with your eye without interference of glasses.
Now, before you replaced my cataracts, I was using granny glasses.
That's
right?
correct.
You know, the little Kmart, Stop and Shop, $2, they went 0.5, 1 point, just kept. When I came out of surgery, within a week or so later, I now can read very, very fine print with no glasses.
That's correct.
What did you do to me?
So what
I
did
like
is
it,
that-
but what did you do?
What I did is I planned the surgery such as the focal point of your eye, the new focal point, the new life that your eye will have, is now designed at that distance. So now, although you can see pretty well at distance without glasses, but your focal point is also designed to be able to read. So you can enjoy both distance and reading. And this usually works for multiple objects, except that for very small print, you probably will still need, in some cases, you still need reading glasses. So the ability of doing cataract surgery is sometimes augmented by implanting special implants that are called multifocal implants that can now focus at distance and reading at the same time.
Now, I remember, now this was years ago when you did mine, you had the straight lenses, which are single focal point, and you had told me that for very far distances, I still wear my long distance glasses. But
Yes.
anything short, like unless the TV is way back there, anything I read, I can see, font 6, 7,
Yes.
really
Yes.
small,
Yes.
which I never could.
Yes, and you can design these monofocal implants to be able to be focused at a specific distance after discussing this with a patient. But you have to remember that a monofocal implant is one distance. And therefore, if you want to look and see far away very clearly, you will need glasses.
Then I put my glasses on.
Exactly. Now, there is newer technology that we can discuss that allows you to enjoy both distance and reading with what we call high-tech implants that are now available for that. But going back to the laser, you can see on this slide how the laser not only makes the incision in a more reproducible way, allows you to relax the cornea so you can correct astigmatism, but also it will make the opening in the lens that we discussed before. That opening is what allows you to access the lens so you can remove the lens. And it will make it with the laser, such as there is the surgeon factor that sometimes, we do have surgeons who are not comfortable with their skills, and this is the most difficult skill for them, is to make a reproducible opening with their own hands. Well, that the laser can do this for them and can add some safety to the procedure if there is a problem with these skills. Now, of course, there are excellent surgeons. I have never had any problem with my openings, but we
But
always
you did
have.
what, 9 today?
I did 9 surgeries
I
today.
gotta say, you got a little practice.
Milford Hospital.
This is not like you're one a week or one a month.
That's
type.
correct. We do perform a lot of cataract surgery. Actually, I'm the busiest surgeon in town and actually in the area. And I do perform other cataract surgery at Waltham Surgery Center, which is Boston Surgery Site. And we do have 65 surgeons at Boston Surgery Site with a huge center with 5 operating rooms. And at Boston Surgery Site, I am the busiest surgeon. And most of the surgeons come from the Boston area. At Surgery Site, we do go to Surgery Site because we do have the access to the laser that, a really very helpful technology that can help us with different segments of the surgery. So you can see here on the slide that not only did we do the opening with the laser, so we have taken away a factor that could cause problems technically if it's done manually, but we have also used the laser to help soften the lens. So now we're not only using ultrasound energy, we're also using laser energy. And the nice thing about this is that when we go to take the lens out, the ultrasound energy needed is much, much less. And in specific cases, whereas the patient has a sick cornea that doesn't take the ultrasound energy, or whereas the lens is extremely hard, that softening of the lens is extremely precious because you're going to reduce the energy placed inside the eye. That blasting energy is way less, and the outcome is much better. The next day, the day 1 vision is much clearer, and I do have patients seeing 20/20 the next day, whereas before you have to wait a little bit for the swelling to go away, whereas you have a huge cataract or you have Fuchs dystrophy. And these cases, we were concerned about them. Fuchs dystrophy, we can touch base and explain what it is, but it's a disease of the cornea where the cornea is very weak. It doesn't have enough cells that can pump the water out from the cornea. So when you do cataract surgery and you have Fuchs dystrophy, you worry about the cornea failing because of that ultrasound energy. Whereas with the new advent of the laser, now we can deliver that energy through the laser and soften the lens and protect and save the cornea, which otherwise would be sick and would need transplantation.
Okay, so you've used a laser, you cut a 2.2 millimeter opening.
That's correct.
You go in there and you blast my lens, you emulsify it.
That's correct.
You suck it out.
That's correct.
Now I have a lensless eye. I have a lens. How do I get the lens through the 2.2 millimeter hole into my eye?
So now you can see on the slide that how the lens will present. You can see that it's a really microscopic optic with 2 tiny small haptics. We call these haptics. There are 2 tiny arms that holds the lens inside the bag. And in order to deliver the lens inside the bag, we fold the lens like a taco, and we put it in an injector that will inject it through the tiny small 2.2 millimeter incision, and that lens will then open up inside the bag like a robot, and then it will take its place, and then you dial it a little bit into place, such as it's now fixed and stable inside that capsular bag. That's how we get it inside.
So you're winding it, sliding it in, and then pop, it opens, and then you adjust it.
That's correct.
Now, you mentioned that you can sculpt my eye. I mean,
That's the sculpting of the eye is really what the laser helps with, and that is by using the laser energy, we can change the shape of the eye, such as we can change the astigmatism. Astigmatism is an irregular shape of the eye. Think about it like a tennis ball that you squeeze in your hands. So now you have a shorter axis and a longer axis. If you have a shorter axis and a longer axis, that is what astigmatism. You have two different curvature for that tennis ball. Whereas if you relax that short axis, then the tennis ball will
becomes more
regain
round
its
and
spherical,
spherical.
exactly like a basketball, perfect sphere. Whereas a football is more elongated in one shape, shorter in one shape. The laser can relax the short axis such as to allow it to relax and to regain as much as possible a spherical
how does it
shape.
relax?
The incision itself, the wound, will relax that tightness in the cornea, and it allows it to regain a more relaxed shape, elongated shape, such as to balance out. And there are nomograms that we use, all computerized, and the beauty of the laser is that relaxing the cornea is not new. It has been done for years and years, but surgeons used to do it with their own hands. The nice thing about the laser is that it does it in a reproducible way, perfectly every single time, in a precise location, and according to a specific nomogram that we use, such as you're not exceeding that nomogram, you're not going less that nomogram. It's perfect every single time. It's really amazing. And that's how we can get to that ultimate goal that you can see on that slide, where people not only are having cataract surgery, so there is no more glare, there is better vision, there is no more blowing of lights around traffic signs, but now people are enjoying their life, they're enjoying their golf games, they're enjoying their tennis games, they are less dependent on glasses, and they are able to really live their life in a more productive way, and in a more, really it's a freedom experience from the
So
spectacles.
now, very self-serving question. You know, many years ago you put cataract, you put new lenses in.
Yes.
How long before I need a retread? You know,
It's actually, you will never need one, never. The implants will live in our eyes for life, and actually they sit in a bag that has no blood vessels, such as there is no rejection, like would you worry about implanting or transplanting tissue.
well, there's no immunological response.
Exactly, exactly. And therefore, implants are supposed to live for life, provided there is no complication, and that we expect them to be there for life. There are some cases where our body will deposit scar tissue on the bag, not the implant. The bag that holds the implant becomes a little bit hazy, but then there is a different type of laser that can remove and can zap that scarring, such as we can regain the clarity of that bag, which now doesn't have the scar tissue on it. So cataract surgery is for life. And once you do it, you usually don't have to change your glasses. Usually it stays the same, short of other things happening, such as it is, fix it and forget it.
So now, when you look at macular degeneration, older fat men like me
Yes.
can get diabetic, and then you worry that you're going to have external factors. How often does that cause you to have to go back in?
You're talking about macular degeneration. Okay, so maybe you can skip the slides, the next 3-4 slides. We can talk about macular degeneration, because I have a few slides here that macular degeneration is something very important because it's an epidemic. And the reason why it is an epidemic is not that we're getting more of that disease, it's because we're living longer. And as we live longer, there are diseases that are age-related. And age-related macular degeneration is exactly what this is. It's age-related. It's due to a long time exposure to the sun and other factors in the diet and other factors that are genetic. And what happens with macular degeneration is you end up having deposits of a substance called drusen, D-R-U-S-E-N, which is a yellow substance that can sit under the retina and cause damage to the retina. And as this happens, it can interfere with the vision. And in some cases, not only does it cause the vision to become a little bit more difficult to read, but the sad thing that can happen is that new blood vessels can grow under that retinal tissue and break through the retinal tissue, trying to heal that area that has the drusen. But by trying to do so, they bring bleeding. And this is when we talk about
So
wet
you're
macular degeneration.
revascularizing
Exactly.
an area.
So we have, on that slide, it shows you what happens when we have bad macular degeneration, when we have a dark circle in the vision, and we call this like a hole in the vision because you can see everything around it, but you cannot see in the center. And if you go to the next slide, you will see how wet macular degeneration, where you have vascularization of that area, can be a very bad thing to happen because that bleeding then will damage the retina. And sometimes the damage is not reversible. So we do differentiate two types of macular degeneration, and people who have macular degeneration know this very well, that there is the dry type and then there is the wet type. And all what we try to do on a daily practice is try to make sure that the dry type is not changing into wet type. And the nice thing about what we do have now, because we're talking about what's new in ophthalmology, we do have injections, medications that are injected inside the eye that can shrink and help stop the bleeding. If you go to the next slide, we can see these injections. Most of them, you can go to the next slide to talk about the injections. Most of these injections actually were privileged because the first one was really researched in Boston, Mass Eye and Ear, and then it became the treatment of choice for wet macular degeneration, which is Avastin. But then we have newer medications like Lucentis and Eylea. The only difficulty with these medications is that, number one, they have to be injected inside the eye, and although this may sound scary, the needle is extremely small, and it usually happens without any pain because the eye is numbed. And the second thing that is a limiting factor with these injections is that you have to have them again and again and again because we still do not have an injection that can last, say, more than 2 months. So we do have in our practice, as I mentioned, Dr. Kamil Ashkari from Mass Eye and Ear, who is a specialist for macular degeneration, and we're fortunate to have them because he is providing the same state-of-the-art care that he has at Mass Eye and Ear here locally in Milford and in Franklin.
Well, I mean, when you talk about injecting into my eye,
Yes.
I remember walking into your office when you started talking about taking a blade and cutting my eye open. It didn't sound like something that I woke up that morning
Yes.
and wanted to go through.
Yes, and it's a very scary experience. Although the technology is helping us, it's helping us because the wounds, if they have to be done by hand, are getting smaller. The technology is getting better, and also there is a way of reducing the need for the surgeons to do parts of the surgery by relying on other technology like the laser to do the same steps that
Yeah, but I
the
guess
surgeon
what
did.
I was scared to death, thinking that you're taking a big knife and cutting into my eye, and you're saying you're going to do less than a 3 millimeter cut. I can't picture 3
Yes.
millimeters. Never mind.
Yes.
In my heart, trust
Yes.
that
Yes.
there's somebody skilled enough.
Yes, yes,
But at the end of it, it really was what you said. I did not suffer. I mean, I'm thinking this is late night movie, punji sticks under the fingers. It's going to be screaming pain, and I didn't come out of there
yes.
feeling. I mean, it was the first day was a little fuzzy, and then you took my little eye patch off, and all of a sudden it was like, oh my God,
Yes.
where did this bright color come from?
That's correct. It's a new world that opens up. My patients tell me all the time how the colors are brighter and more vivid. And they do regret not having done the surgery a long time
Yes.
before. Because one of the things that our brain is able to do, we are able to
Compensate.
adapt, we compensate, and we think that the world is supposed to be this way
Yes.
until we get rid of the cataract.
I thought I had a
Yes.
stupid computer screen
Yes.
that was dull
That's correct.
till
it's
you did my eye, and all of a sudden I was like, okay, is this what it's supposed to look like?
Yes, and I tell my patients all the time, when they hear that they have a cataract and they tell me, doctor, it's time to do it, I cannot function anymore. I tell them, don't think about the glass half empty. Think about it maybe half full and probably more than half full. Because as we discussed earlier, this is not only an opportunity for you to see better, but also maybe to reduce your need and your dependence on glasses. So such as you
I
are
had
achieving all
20
this.
pair of granny glasses. You know, I'd buy the 6-pack because everywhere
Yes.
I had them,
Yes.
I'd forget where I put them. It was such a pleasure to take them and donate
Think of
them.
them. Absolutely, yes.
Yeah.
Yes, and we forget that although glasses can allow us to see, but there's still a device, and the vision through the device is not as good as our vision without that device. And that's why we try all the time, like I tried with you, and even now with better technology available for different cases and different situations, to correct astigmatism, to correct the need for reading, and to treat this component of the surgery is to treat this part at the same time as what we call the refractive component, at the same time as treating the cataract surgery.
Now, years ago, you started hearing about LASIK and doing something to the eye, which
Yes.
again scared the living out of me, that somebody's going to be playing with my eye. When would I use LASIK versus what you're talking about?
So the LASIK, once we have a cataract, the LASIK cannot be done anymore. LASIK is reshaping the cornea with the laser to correct the need for glasses. But if we think that the cornea is reshaped, we definitely have to make sure that there is no cataract. The time you have a cataract, then you're defeating the purpose, because that cataract will change over time. It will change your prescription as it changes, becomes more cloudy. Then why are we doing the LASIK? So therefore, the time there is a cataract, then the LASIK is no longer indicated.
But you're essentially, with the new laser technology, giving me, I can do the best of both.
That's correct. The new laser technology is to remove the astigmatism on the cornea. At the same time, I remove the cataract.
At the
And this
same
is-
time, you give me a new lens.
That's correct. And this is for small degrees of astigmatism. If the number is within a certain range, let's say up to 1.25 of astigmatism. But then when you have more than this, then we have special implants where you can correct the astigmatism and the cataract at the same time.
So now, if you correct my astigmatism, and then you give me a new lens, I'm happy. Does the astigmatism ever get worse?
It is unlikely to go back to the same amount you had before. As the eye ages, we can have a little bit of astigmatism because the shape, with the lids becoming heavy, they push on the eye and distort the shape. But we don't expect it to be such as you will need glasses or you will need another surgery.
So if I was at 1.25, you fix me, I'm not going to go back.
It's most likely no.
So now, one of the things we had to discuss was what kind of lens do I want?
Correct.
Because back
Yes.
when you did mine, they had the lenses that, I guess they were called progressive or
Multifocal.
multifocal.
Yes.
But it felt like, okay, I can get good vision across abroad,
Yes.
or with the single focus, I can get great vision. And I have to wear glasses when I want to drive or look far away.
Exactly, and that's where the discussion between the patient and the surgeon is very important to assess the need of all of us have different needs and different aspirations of what we want to do. And as you just mentioned, we have different ways of trying to achieve these goals. If we go back a few slides, you will see that there are different implants that we discussed before. And I will walk you through this slide because you will see one before. Yeah, keep on going. I'm sorry. Just go back. One more. Yeah, keep on going back. I'm sorry. Yeah, the next, this one. So you can see on this slide how the regular lens has no built-in reading or correction for astigmatism. So it corrects for one distance, and that distance is designed and planned based on the patient's needs and interests, whereas we can build in that lens multifocality called the multifocal implant, and that's the one in the center. If you look very carefully, you will see rings inside that lens.
Right.
Each one of these rings has a different focal point, and because our pupil will change its shape, when we read, our pupil is smaller. When we look far away, it's larger. So the engineering of this lens is such that at a small pupil size, you're catching more power in the lens, so you can read. Whereas at a far away distance, you're catching a different zone, such as you can look far away. So this is called a multifocal lens, exactly like you would long time ago, before you had your cataract surgery, you had probably
progressive.
progressives. Exactly. So now you have the multifocal lens. And then if you look at the lens to your far right, that's what we call the toric lens. A toric lens is a lens designed to correct that astigmatism. And if you remember, we discussed how there is a short axis
Right.
and a long axis.
Football versus basketball.
Exactly. So you go to that football shape and you align the axis of that implant to the patient's axis that is short. So now that lens is negating or canceling that short axis. And now we have treated the astigmatism. So there are different options, different possibilities of treating the need that the patient has. And it all depends on their needs, what they like to do, how independent they are, if they are out doing a lot of sports, if they like to read a lot, etc., etc.
But now, is the quality across a multifocal lens the same as a short lens? Like, I'm perfectly happy that I'm on my computer, I never wear my glasses.
That's correct.
Okay,
Yes,
I can, you did it so I can
Yes,
see, I'm reading, I've got my tablet.
yes, yeah.
That,
So the multifocal lenses probably are never as excellent as a monofocal
okay.
lens because they do provide for different focality.
Right.
And with this comes down a small decrease in the contrast because you cannot fix everything and have the same.
well, no, but the
quality of lens.
resolution, when you start looking at each of those rings,
Correct. Is not as good
I got
as
one
lens.
big ring that is perfect for here,
Yes.
and then I got my glasses to fix me.
That's correct. And that's why, you have to discuss the need of the patient and how, what their things that they do in life and what they are and how they look at them being independent and if they are ready to give away a little bit of that one distance if they want to be able to be functioning at different distances.
Or live like me and just have a pair of glasses,
glasses
and
with
put
you.
them on.
Correct.
So, make a decision. Like, I came in to you, I said, I'm starting to get nervous because I can't see the signs. I can't drive well. The TV is looking faded. I need cataracts. So we had the discussion. One of the things was which lens. Is there really any other discussions that you're going to have?
We do discuss the surgery itself, and I do discuss how we do the surgery. I do my surgeries with topical anesthesia. This means I do not use any injections in and around the eyes, just drops. Topical means drops. You numb the eye with drops, and the anesthesiologist working with me will give the patient something to relax, and 7 to 10 minutes later, the surgery is done. We have to be careful about which type of anesthesia you are going to get, and this is a very important question patients have to ask because you want to avoid as much as possible the injections around the eye. These injections can cause bleeding. There is a risk with this injection of paralyzing the muscles, or sometimes we have complications like the medication from the injection going deep inside the nervous system and causing respiratory problems. Or unfortunately, sometimes these injections going inside the eye and causing even more difficult problems. So for me, I have decided from the beginning that I want to do my cases without the injections, and that's what I do. But I think that all patients have to ask their surgeons, what type of anesthesia do you use and why? And I think, in my opinion, that whenever you have a chance to avoid the injections, that would be a better choice, in my opinion.
Well, I mean, any type of anesthesia. There's a reason we have anesthesiologists.
That's correct.
There's a reason people specialize in nothing
In that
but
domain.
that.
That's correct, yes.
Yeah. There can be serious consequences no matter what kind of anesthesia.
That's correct. Although we are lucky in ophthalmology because when we do our cataract surgery, we joke about it, but the anesthesiologist, more often than not, they're really doing nothing. They relax.
But that's good.
Because it's a very mild anesthesia.
Dr. Kaldawy, a
Yes.
board anesthesiologist, I'm happy.
Yes.
My anesthesiologist
I'm
has
happy with-
nothing to do.
That's correct, because the anesthesia we use is what we call short-term anesthesia, and many patients are able to regain their activities just after the cataract surgery, go back to normal regular life, I had patients who asked me if they can go to work because they felt very good that same afternoon. More often than not, we recommend to take a day off, but that's basically it.
Now, I'm going to have a discussion with you, but how do I choose my ophthalmic surgeon? I mean, I chose it because people told me you were one of the busiest ones around. I said, somebody with a lot of practice is a good thing.
Yes.
You know, because if everything goes perfect, a normal ophthalmic surgeon can handle it. I worry.
Yes.
I like the fact you're doing 9 a day, because the odds are pretty good that you've run into any problems that my old body can present.
Yes.
But how do you know?
So it's very important to ask questions. And many surgeons may project themselves as good surgeon and may project cliches like best eye doc or things like this. But we have to be careful, because until you ask the specific questions, this is when you know what you're going to get. And the specific questions would be, what is your complication rate? How many cases end up with breaking the bag that holds that lens at the end? One of the most dreaded complications of cataract surgery is that the surgeons, as the surgeon is doing the surgery, there is an accident that happens where there is a problem on the bag, a tear in the bag, or there is a defect in the bag that allows the lens material either to fall deep inside the eye or the gel of the eye to go up to the front part where it's not supposed to be. And this, more often than not, will cause serious problems, if not right away in the future. So one of the things we do at the surgery site in Boston, where I do most of my surgeries, is that we have 65 surgeons with a committee designed to track complications. So we do track complications, and if a surgeon is falling into many complications, we ask that surgeon that maybe it's better not to operate anymore. And whenever you go to have cataract surgery, ask that surgeon if they have an independent committee in that center providing these statistics, and if these statistics are ever collected. The other complication, which is really serious, is infection after cataract surgery. That's probably even more serious than the first. And in my surgery center where I operate, we have a committee that tracks infections, and we report this infection to the state. So you want to make sure that you know how many cases are complicated by infection. We discussed the type of anesthesia. You have to ask your surgeon what type of anesthesia he or she will use. Is it topical drops, or am I going to get a shot to numb my eye? The other question to ask, am I going to have a stitch to close the wound? Because the better and preferred option for cataract surgery—
Are you using like BioGlue or?
Nothing. Remember, we do a 2.2 millimeter surgery. A 2.2 millimeter surgery needs nothing. It shuts off on itself like an automatic valve. Whereas other surgeons may still use stitches, and although that stitch can be hidden under the skin of the eye, it's still a stitch right there. And that stitch can end up causing distortion of the shape of the eye by inducing an irregular shape for that eye.
Are these bioabsorbable stitches? Or?
They are bioabsorbable stitches that can absorb on the long run, but the shape on the eye can be induced, such as there is a problem after surgery.
So you
with
can hold it
astigmatism.
the wrong way and create an artificial stigmatism.
Exactly. You're creating what we call surgical astigmatism from the stitch.
So now how do I learn? If I want to find out, is it 1 in 100, 1 in 1,000? What would you say is a acceptable rate
of complications? So the American Academy of Ophthalmology takes as 0.5% the rate of complications with posterior vitreous presentation, which means that we have to have less than 0.5%.
So 1 in every 200
cases of operations. And there are many surgeons who can tell you that this is an independent— for instance, at Milford Hospital, we have an independent entity that tracks the complication rate, and they can present to you at the end of each year with your complication rate. And you have to learn from that independent committee or independent person what the complication rate is.
But as a patient,
yes.
Okay, I'm driving down the street, I've decided I really want to read the signs. I want to be able to see my TV, and I don't want to curse at my monitor. I need cataract surgery. Okay, how do I learn what your complication rate is? Where do I go?
The
Because
ulti-
if I go to you and say, are you a good surgeon? What are you going to say? No? It's like, do you love your mother? Of
Yes,
course.
Yeah. That's a very good question. And ultimately, there are new changes and trends in ophthalmology where Medicare is going to start tracking complication rate and becomes mandatory. And there is something called pay for performance, PPP. Pay for performance is a program whereas the surgeon compensation will be in part related
On the quality of the care they give.
Quality of the care, not only the care given. But before we get to that phase, you have to ask the surgeon. Don't hesitate to ask the surgeon. There are unfortunately surgeons who can blame the problems on the patient. And this is very sad. And I've seen these patients every day come to me for a second opinion. So you go to a surgeon and there is a complication and the surgeon tells the patient, that's because your cataract was very big or you let it go too far. And that this is what happened.
But where do I start?
Yeah.
I mean, I want to pick my surgeon.
Uh,
With you, it was easy. I got referred.
Yes.
But if I just moved to Milford, I don't know anybody.
I would tell you, ask your neighbor who did the cataract surgery. Ask your neighbor who had an excellent experience who did your cataract surgery. And how can you see now? Are you happy? Did you fall into problems? How was your experience through the procedure? Did you get sutures? Did you get an injection? Did you get to the point where you had to use a special lens and not the other lens? In our practice, we only use the best lenses and we don't compromise. It's not on for that patient we're going to use a lens or that lens. It's for everyone.
Now,
the
wait a
best
minute.
quality of lenses.
With the price of the surgery, somebody would really try and buy a Kmart lens. I mean, how much could I save on a cheap lens?
Unfortunately, this does exist, and there are lenses that are different than others that can do different things, and they are offered sometimes in different practices.
But Roger, how
but
much are you going to save?
Exactly. That's what I tell my patients. You have only one chance to get the best implant, and I would recommend to go with the best implant.
Cataract surgery will run, on average, how much?
The surgeon fee is really not the problem. The cataract surgery is mostly the facility fee.
Well, I need
and
to
the
pay the
anesthesia team.
hospital, the anesthesiologist.
Exactly. And
But all in,
well, I would say probably around $5,000 for cataract surgery, but that is not for the surgeon. That is for the hospital anesthesiologist. Medicare pays the surgeon right now in the around $600 per surgery, and that is the current Medicare
so
payment.
somewhere around $6,000, all in.
That's probably what.
How much do I save on El Cheapo lens versus a good lens? Is it $100?
That's probably around that number, around that money.
So
you know,
somehow, out of $6,000, if I go and I get the best care, I get the busiest, most experienced surgeon, instead of paying $5,900, it's $58, and I've got a cheap lens. For the love of God.
Yeah. Well, you know, just remember that the surgeon has to be forthcoming and explaining the different type of lenses and ask the patient to make the choice rather than choosing for the patient. But that's a different situation.
No, but from a quality point of view.
Absolutely, I agree with you.
You know,
I agree with you.
I'm not going to know. I look at the type
Yes.
of lens. I can make the informed decision like we did.
Yes.
That I want better vision, and I'm too old to be vain. So I'll put on glasses when I got to look far.
That's correct. And
But if you told me what's the best lens on the market today, in your opinion?
well, there are a lot of good lenses, but there are also different lenses that tend to be less expensive.
Well, that's what I'm
and
saying.
then,
If,
you know, that's
if
correct.
you told me use a Bausch and Lomb or a Schmickley and Bickley, I wouldn't know the difference. I've got to trust you.
That's correct. You know, that's unfortunately you have to trust the surgeon, but also you have to ask specific questions. Why do you use this lens? And what is the difference between this lens and another lens? And in doubt, just have a second opinion. You know, we can always answer questions and explain the differences. Go to the internet. The internet can be a huge resource for information about different
Well, see,
lenses,
that's what I was
different
thinking.
implants.
If I go and do a Google search and I look at the top 5 lenses used in the USA, and I can come to you and say, I found red, blue, green, and yellow.
Yes.
In your opinion, which one is the best for me? And if you say red, then I go visit somebody else and he says red.
Yes.
Well, I'm feeling comfortable.
That's correct. That's one of the ways, and also is to sit down and have a discussion about different lenses, the positive and the negative of each one, and allow the patient to make a choice.
But I still, as a patient, I'm relying on you giving me the right
That's
information.
correct. We can orient the choice by, for instance, I tell my patients that when I'm going to have my cataract surgery, I'm going to have one chance. That's it. To have it done, I want to have a quality lens and hopefully be independent from glasses. Because in my case, I have the opposite problem like you. I do need reading glasses when I want to read, and I feel extremely inconvenienced by having to put the glasses on and remove my glasses, and I lose them all the time. I have them everywhere, so it's extremely annoying. So when I finally need my cataract surgery, I'd like to be able to take care of this at the same time.
So now, you say you do your surgery at Milford Hospital.
That's correct.
Should I ask my ophthalmic surgeon, where do you do your surgery?
That's correct. And also why. And also, unfortunately, it's a question that should come up, is that do you have financial interest in the surgery center where you operate? Because this is a factor that has to be entered into the equation, whereas your referral to one center or the other, where if you are going to that, for instance, if I didn't have access to the laser and my patient needed to have laser surgery because they have Fuchs dystrophy or a cataract that's extremely dense and would benefit from the laser, I would refer my patients to a center that offer that laser. So my presence in a center that doesn't offer the laser should not be in the best interest of the patient. And that's a very important
I see what
factor.
you're saying.
Yes.
If the best course of action is a laser, you should pick the facility with the laser.
That's correct.
Not saying, well, my garage has a non-laser facility.
That's correct. And then we can do it here,
But when you say financial interest, I mean Milford Hospital, Boston Eye and Ear.
Yes, the biggest eye centers have ophthalmologists who are part of the faculty. And by the way, one thing that I didn't mention is with the laser, bladeless cataract surgery, it so happens that on a yearly basis, we have US News and World Report that comes up with the classification of the best eye centers in America. And I can tell you that the 5 best centers, one of them is Mass Eye and Ear, but all five centers offer laser bladeless cataract surgery. All 5 centers have adopted that technology. The American Society of Cataract and Refractive Surgeons have approved the procedure. They are using it, and the FDA has approved it. So you may want to wonder, if the best 5 eye centers offer that technology, shouldn't my eye surgeon be able to offer it as well? And that's why I decided that I would be able to do part of my cases in a center that is able to offer that technology, which, by the way, is the same center where some of the Boston surgeons do their cases.
So realistically, if I come to you in Milford, does Milford Hospital have a laser?
They do not have the laser.
So if you wanted me, because you said the best treatment for you is laser, you would take me to a different facility.
Exactly.
But I still get to use the surgeon that I want.
That's correct. I will be in that facility. I can do your surgery, but in that case, you will be doing it at Surgisite Boston, which is in Waltham, Mass. And we do have really a wonderful service over there, state-of-the-art facility, 5 operating rooms, and they do provide transportation, door-to-door service where they come in, they pick you up. You go to a center where there is state-of-the-art technology, where there are 65 world-class surgeons from Boston operating, and where people are able to trust that there are surgeons monitoring surgeons. And you can get the best care, nursing, and the best care in technology and equipment.
So the surgeries you do at the Milford Medical Center are the ones that don't require
Laser surgery.
laser surgery.
Yes, or either the patient elects not to have laser surgery. So when we explain to them that there is a way of doing it with a laser, and then the way that is without the laser, the patient says that I trust your hands and I'm comfortable enough, let's do it without the laser. So in that case, of course, they're more than welcome to come in and have it done at Milford Hospital.
So
The choice is always to the patient. And by the way, our center does not charge extra for laser bladeless cataract surgery. Our center, when you need, let's say, to remove your astigmatism because you need to get a multifocal lens and you have some astigmatism, our center will pay for that laser fee from the center at the surgery site because we have as a priority, myself, I have priority that I want to provide the best eye care possible. So we do not charge
So
for
the
laser vision.
CPT code is going to pay you to fix my cataracts.
That's correct. And then
How you do it, up to you.
up to you, up to also the multifocal implants though and the toric implants, there is an extra charge for this because the Medicare insurance and the other private insurances.
Well, they'll pay for the best
the best.
regular lens.
That's correct.
If you
And
want the fancy one, you pay
yes,
a little
there's
bit
extra
extra.
charge. That's correct. Yes.
Out of the $6,000, how much of it's covered by insurance?
It's all of it is covered by insurance.
okay.
Yes, yeah. Medicare covers 80%, and most patients have an ancillary insurance
Right.
that covers 20%. So cataract surgery, because it's a medical diagnosis, and in fact, I'm not sure if you know that cataract surgery is the most common surgery done in the United States.
Oh, I didn't.
3.6 million procedures done every year, and this is because we have huge need. We were talking about our population aging. The baby boomers are now in the age where they require cataract surgery, and we are all living longer with the newer technology in medicine, but also we want to live a more functional life. So as we are living longer, more and more patients need cataract surgery. And knowing that it's a medical diagnosis, all insurances cover that procedure.
Besides cataracts, well, not days you have 9 operations, but what else brings people to your office? Do you do traditional
Yes.
glasses? And
Yes. Well, you may be surprised, but we do take care of every single type of problems in ophthalmology. Let it be from the 5-year-old child who comes in because they cannot see well, all the way to the 105-year-old lady who is now 105, but she cannot see, she cannot read, and she needs cataract surgery, or she has macular degeneration. So my domain is also in cornea and refractive surgery. So I do some laser vision correction and corneal transplantation. And with corneal transplantation, the domain is amazingly evolving, whereas now we have newer transplants that are less invasive. We can repair corneas by remodeling the cornea in special disease called keratoconus, where the cornea becomes pyramidal in shape. In the past, used to do transplants. Now we can rebuild the cornea.
Are these cadaveric transplants, or where do you get them?
The transplants are really a donor transplant for people are
from
very
cadaver.
generous that indicate on their driver license that when we pass away, we want to donate our corneas. And this will is well honored upon their death, and the tissue bank collects the cornea, and then we can reuse that same cornea after checking it for multiple ailments and diseases. We make sure it's clean. The tissue bank will bring the cornea to the hospital, and this is where I do my cornea transplantation.
Now, do you have to deal with immunosuppressants and all? I mean, it's foreign tissue.
We are blessed in cataract and corneal transplantation. I started the program here at Milford Hospital. It was the first program in the area for corneal transplantation 12 years ago. And I'm very blessed to have success in that domain, not only because I'm able to do the transplantation, but also we do not see many rejections. The rejection rate is extremely low. And one additional reason for that is that the cornea itself doesn't have a lot of blood vessels and doesn't require that much anti-rejection medications.
Amazing. I'm always amazed at the level of expertise available here in our little town.
Absolutely. I'm very proud to bring this expertise to the town. I started my career in Boston as professor of ophthalmology at BU, and I have trained fellows and residents. And then as my kids were growing up, we decided that Boston is no longer a good place for us. So we moved closer to the suburbs, and I am right now very happy to have made that choice. The difference that I can make on a daily basis in people's lives and vision is very gratifying. And I can tell you that it has been a beautiful journey, and I continue to enjoy the success and good reputation from our lovely patients who come to see me on a daily basis, and from growing from word of mouth, really. When I came here, I didn't know anyone. And at this point, I'm extremely busy, and I'm proud of this based on the results we were able to provide.
Well, we thank you for providing these services, and as always, get to know what's available here in the center of the universe. It's amazing not only the depth of experience that the medical community here delivers, but the breadth. More and more, I always learn that we are extremely fortunate to be here in Milford and have MDs and surgeons who just can't be beat.
Thank you all very much. It has been a pleasure, as always.
Thank you. And as always, may God bless. May tomorrow be a healthier day than today. Good night to our 6 loyal viewers and maybe 1 extra. Thank you for joining us.
Thank you.
Not too long since I've been home. Been running all my life just